Hello, I'm Dr. Brian Cole, and over the next few minutes, I'm going to present the arthroscopic approach to the management of articular cartilage defects. I think the first question that we need to ask ourselves is, does it really matter whether we approach an articular cartilage problem in an open fashion or an arthroscopic fashion? I would argue that there are some inherent advantages to doing an arthroscopic procedure, but it may start on the front end when we consider all of the aspects of decision-making. The first thing to understand is that decision-making in the management of articular cartilage problems is not linear. It requires a complex clinical evaluation to assess for concomitant pathology, certainly an appreciation for previous surgeries, and the goals of care. Underlying our decision-making is the principle that it is possible to follow the natural history of a patient when they have low-level symptoms. In other words, the art of doing nothing embodies the fact that oftentimes symptoms may be moderate and not require treatment at all, despite the presence of objective evidence of an articular cartilage problem. In addition, we must remain mindful of all the comorbidities such as malalignment, ligament deficiency, and meniscal deficiency when contemplating treatment for articular cartilage disease. In principle, all of the procedures that we do can be performed arthroscopically. However, the ones that we see here in green are the ones that we most commonly contemplate for this solution to be performed through a minimally invasive procedure, such as use of the arthroscopy. Arthroscopy in general can be particularly helpful because it's not only diagnostic, it might indeed be therapeutic. In this instance, we see an articular cartilage lesion with subchondral change by MRI, but an associated video at the time of arthroscopy showing significant delamination and a zone of injury that is much worse than we would have anticipated based upon the initial MRI. It's also important to know that articular cartilage and meniscal lesions are quite common in all comers, independent of age and activity level. There is actually more than one right answer when we treat articular cartilage problems, and it might respond to debridement, marrow stimulation, some allogeneic surface treatment, osteochondral grafting, potentially MACI or cell-based technology, or an osteochondral allograft. And the decision-making can be quite complex, maybe. And what I mean by that is that there are many solutions that might be used to solve the exact same problem. But typically we break it up between femoral condyle and patellofemoral joint, and then by lesion size and physical demand levels. And then we take into consideration whether or not it's the primary or the revision treatment. Now, debridement and chondroplasty is often considered palliative, and it's actually quite simple with low resource intensity and can delay further treatment in up to 60% of patients. I would say it's generally ideal for acute symptomatic patients with mechanical symptoms. It can be used in high-level individuals who need efficient but maybe short-term relief. Smaller defects can be quite responsive, and our older, lower-demand patients seem to be the most responsive. Defects like this that are arthroscopically determined to have unstable edges may be the most responsive to articular cartilage debridement. We know from our work in looking at the fate of patients who do not undergo ACI following initial biopsy that about 40+% of them actually get symptom relief following initial debridement. We think that establishing vertical walls may lead to improved load sharing between the abnormal and normal articular cartilage, rendering the defect less symptomatic. Debridement and chondroplasty, as seen in this example here with a patella defect, which has unstable edges, can easily be treated arthroscopically, undergo some form of, say, marrow stimulation by violating the calcified layer, which may lead to some longer-term benefit. But the initial benefit can often be achieved simply by debriding the defect itself, getting rid of the mechanical element of it, and also minimizing the biologic debris that's present at the time of surgery. In addition, augmenting it with some type of growth factor therapy, such as the use of platelet-rich plasma, bone marrow aspirate, or other, might prove to be beneficial. But formal marrow stimulation as a reparative treatment is used to promote autologous chondrogenesis. It's a single-stage procedure that's less demanding than some of the other restorative options and can obviously be performed arthroscopically. It may be ideal for younger patients with relatively small to medium-sized defects in the 2 to 4 square centimeter range. But our threshold for very active patients tend to be in patients less than 2 square centimeters who we think may not otherwise respond to debridement or have longer timelines to show improvement. It's also more ideal for isolated injuries with minimal subchondral bone involvement. Marrow stimulation has shown excellent return to sport rates as high as 80% in 9 months in some studies, and it might be equal to other orthopedic procedures when other variables are normalized. This study looked at a cross-sectional analysis of virtually all high-level sports, showing very good return to sport rates in terms of percentages. There's been some evolution, however, in marrow stimulation. We've investigated the role of drilling compared to use of a standard microfracture awl and showed that our awl versus drilling revision rates were 41 versus 17% respectively. Below are images seen from our microfracture awl patient versus a drilling patient, where we see much less subchondral bone excitement. Clearly, our goal is to generate some type of hyaline-like cartilage within the defect. So defect preparation is critical, but establishing normal postoperative protocols that protect weight bearing in the early phases to shield the subchondral bone from overactivity might also be important. And we now believe that drilling is a less invasive, if you will, or less dramatic way to excite MSC egress without traumatizing the bone excessively. So this is a case example of a defect that you see here that we felt might not respond to debridement given the absence of any significant cartilage defects that would otherwise lead to mechanical symptoms. In this instance, drilling was performed after violating the calcified layer, creating vertical walls, allowing this young athlete to return back to sport, and it was also augmented with bone marrow aspirate that was concentrated. There's other ways to improve marrow stimulation. Orthobiologics such as PRP and bone marrow aspirate, scaffold augmentation with collagen or extracellular matrix, the AMIC procedure, which is commonly performed in Europe, and cell-based repair such as minced autologous tissue, and even some surface allogeneic options as you see here. This is a procedure, biocartilage, which used allogeneic articular cartilage in its anhydrous form. The initiation is seen here in an animal model that was performed in collaboration with Lisa Fortier. In an equine model at 13 months, we compared marrow stimulation to biocartilage with marrow stimulation, as you see in the videos on your left. Our overall repair scores were superior, and we saw increased type 2 collagen staining in those that had biocartilage or type 2 collagen coming from allogeneic articular cartilage that was in an anhydrous format, as you see here, arthroscopically delivered in the bottom right, where there's a mixture of PRP with the allogeneic collagen, as well as placing fibrin glue over the top of it to secure the defect. We recently published in a level 3 study, 48 patients looking at patient-reported outcomes, all of which improved compared to baseline, as you see here, including improvements in the MOCART score as assessed at 2 years. This is another example. This is an example of using Autocar. Autocar essentially is taking autologous cartilage from the intercondylar notch as a source of cells and maybe matrix, adding a scaffold such as biocartilage or allogeneic collagen, and a signal such as PRP or bone marrow aspirate. So this is basically a way to augment the typical scaffold-induced marrow stimulation technique. So this is a case example of a defect seen in the trochlea. The defect is prepared in the usual format. The defect is prepared by creating vertical walls. We'll drill with a micro drilling procedure. We will capture autologous cartilage from the intercondylar notch, as you see here. It's captured in this receptacle that's placed on the end of the shaver. And we create a mixture of allogeneic cartilage, autologous cartilage, and some source of growth factors such as PRP or bone marrow aspirate. This is typically mixed on the back table. Then it's introduced arthroscopically into a dry field. Dry arthroscopy is relatively easy to perform. And these patients are treated postoperatively, much like we treat marrow stimulation. This is a technique that's courtesy of Jason Dragoo, looking at another form of arthroscopic treatment using particulate juvenile cartilage implants. This basically shows the sequence of the initial lesions that's prepared, as we've shown you, with violation of the calcified layer, creating vertical walls, and adding juvenile particular cartilage with fibrin glue, very similar to the Autocar procedure that I showed you previously. There are some other restorative treatments that can be performed arthroscopically. And again, these restorative options are to replace diseased tissue with healthy autogenous tissue, and generally have provided excellent outcomes. They're ideal for defects that are slightly larger, with or without subchondral bone involvement, and can be used as a salvage after failed repair. I think the research supports that an osteochondral autograft transplant is a dominant treatment strategy for relatively small defects when compared to marrow stimulation alone. Osteochondral autografts now have been shown to treat even large defects, as we see in this study by Mukai in OJSM in 2019, showing that even large defects treated with multiple plugs that were spread out basically led to improved outcomes compared to other treatments. An osteochondral autograft is a pretty straightforward procedure that can be performed arthroscopically at the insertion, but the harvest is often performed, as you see here in the middle picture, with a small arthrotomy to get tangential and perpendicular to the articular surface of the proximal trochlea. This is a Macy procedure that was also performed arthroscopically, courtesy of Andreas Gamal. And essentially, this is a technique that, as long as you get good defect preparation, you can easily perform it arthroscopically. Most easy, I think, in the trochlea, but can be performed in the tibia as well as the femoral condyle. This technique, courtesy of Alberto Gobi, demonstrates a single stage technique using bone marrow aspirin and hyaluronic acid. And while this is done through a mini arthrotomy in this picture, he is able to do this arthroscopically as well, with contoured cutting guides and instrumentation. I think in the end, it's important to manage our patients' expectations and know the literature and your own experience. We know that non-operative treatment can actually provide beneficial symptom relief for many of our patients. We also know when we can achieve successful outcomes, but I think we've learned more to date from analyzing our poor outcomes, as you see here. When we've looked at our outcomes after cartilage replacement, we often see about 30% of these patients come to subsequent treatment, most commonly arthroscopic treatment for debridement. But fortunately, about 65% of those will actually improve after arthroscopic reevaluation. So in summary, there's a large incidence of articular cartilage disease that may never cause symptoms. Arthroscopy does play an important role in the care and treatment of articular cartilage lesions, and as technology advances, all procedures may be performed with less invasive techniques. But keep in mind that we must still evaluate and treat all comorbidities. Thank you very much for your attention.